Center for Excellence in Aging and Lifelong Health. I wanted to take just a minute to tell you about Riverside Health System and our center before I pass it to our keynote presenter and moderator, Dr. Gaugler. He will then introduce the panelists. Riverside Health System, as you may be aware, is located in the eastern part of Virginia. And with more than 10,000 Americans turning 65 every day, we recognize there's never been a greater need than now to serve our aging community. And our fundamental belief is to keep our customers and our patients in control of their destiny in a place of their choosing. And to help fulfill this, we've assembled one of the largest integrated networks of services for older adults in Virginia, known as the Riverside Lifelong Health and Aging Related Services Division. This division includes continuing care retirement communities, assisted living residences, memory support, skilled nursing and long-term care, inpatient and outpatient rehabilitation services, and wellness and fitness centers. We have a number of community-based services, including home health, hospice, and palliative care, and nearly 1/3 of Riverside Health System employees work in and are dedicated to the Lifelong Health and Aging Related Services Division. The Center for Excellence in Aging and Lifelong Health, which is helping to sponsor this panel today, provides direct services including a geriatric assessment, a driving evaluation clinic, dementia care consultation, and community-based education and research to support older adults and their family caregivers. Our center is currently partnering with Dr. Gaugler and his team at the University of Minnesota. And I'll tell you as we wrap up today a little bit more of one of the studies that we are doing with Dr. Gaugler and an opportunity for you to participate. Now I'm pleased to introduce your keynote and our moderator, Dr. Gaugler. Dr. Gaugler is the Robert L. Kane Endowed Chair in Long-Term Care and Aging in the Division of Health Policy and Management and the School of Public Health at the University of Minnesota. He also directs the Center for Healthy Aging and Innovation in the School of Public Health at the University of Minnesota. He's an applied gerontologist with interest focusing on Alzheimer's disease and long-term care, the longitudinal ramifications of family care for persons with dementia and other chronic conditions, and the effectiveness of community-based and psychosocial services for older adults with dementia and their families. He's currently serving on the editorial boards of 3 major gerontology journals and has a number of distinguished awards, both regionally and nationally, for his work in dementia care. He has a number of journal publications and several books, and the newest of which is called Bridging the Family Care Gap, which talks about the state of family caregiving and highlights the impact that families and societies and policy can bring to the realm of dementia care. So with that, Dr. Gaugler, thanks for being with us this morning and helping to host the Dementia Q&A panel.
Well, thank you so much, Dr. Jensen. Thank you to our panelists who we're going to hear from shortly, as well as to the many of you who have chose to join us here today. You know, again, our original plan and goal was for me to be in person in Virginia. Unfortunately, you know, for reasons we all understand, we are doing this fully remotely, but nonetheless, we are really excited to have you here with us this morning. This structure is a little bit different, certainly compared to other perhaps presentations maybe you've taken part in or have attended, certainly that I have given, where this isn't really a traditional kind of keynote address where it would just be me putting up slides and going through a particular topic. Instead, we're modeling this off of a really successful event we did earlier this year, this Q&A panel format. And the reason why we wanted to utilize this structure for this particular presentation is it really offers the opportunity for us to answer your questions. There are many, many questions that come up related to living with dementia, caring for someone living with dementia, and we wanted to ensure as interactive a webinar experience as possible. So I want to thank all of you who have submitted questions prior to this panel. because that is essentially going to be the first part of the panel. We're going to have our esteemed panelists address your questions. And then in the second half of the panel, we will take that opportunity to address any questions that you bring up now. So what we would ask you to do is, while you're listening to our great presenters, is to use the chat option, or more specifically the Q&A button at the bottom of your screen, to actually ask questions. And then what I'll do is I will look through those questions and I will direct them to our panel to help answer for you. And again, we hope that this helps get at some of the really critical issues that maybe you're going through or someone you know is going through related to dementia or dementia care. So with that, I would like our panelists to introduce themselves. Again, just so excited to have this reservoir of expertise available for this particular presentation. We'll start with you, Dr. Fox, if you wouldn't mind introducing yourself.
Hello, I'm Jackie Fox. I'm an occupational therapist at Patriots Colony, and I work in the convalescent center. So I work with people that have come from the hospital, as well as individuals in assisted living and even in independent living. I have several family members with dementia, and so this is a topic that is near and dear to my heart.
Thank you so very much for being here. Dr. Purdy, please.
Yes, thank you. So my name is Jennifer Purdy. I'm a pharmacist with Riverside. I'm a clinical pharmacist, so that means I don't actually work in a pharmacy and dispense medications. I get to work directly with patients, their caregivers, and their providers, and work towards optimizing medications. I'm board certified in AmCare and geriatrics, and that's really what I'm passionate about. So happy to be here today.
Wonderful. Thank you so much. Dr. Armstrong, please.
Good morning. Thanks for inviting me. I'm Vicki Armstrong. I'm a gerontological nurse practitioner, and I am currently program coordinator for Riverside's Memory Care Clinic in Hampton, Virginia, in the neurology division.
Wonderful. Thank you. Travis, please.
Hi, I'm Travis Greenman. I'm chaplain at Patriots Colony, and I traveled the road of dementia with my own mother through the end of her disease, and I am a positive approach to care certified trainer, and it's done a lot of research and, of course, and run a support group here.
Wonderful. Thank you so much. So I thought we could go ahead and just kick things off with our panelists addressing some of the questions you submitted prior to the panel. And I'd like to start with you, Dr. Armstrong. Maybe if you wanted to summarize some of the questions that you're addressing in your kind of brief presentation here.
Thank you very much. So there are many different types of dementia, the causes of dementia, and then there's different stages. So commonly, people are concerned about memory loss as we age, and there is normal aging memory loss for people as we get older. There are normal aging changes in our brain, and those normal aging changes are responsible for some of the things that most people will experience as we age. One of the most common things that people will talk about is you get up, you walk into another room to get something, you get there and you can't remember what you went there for. You know, and people commonly joke about this. Oh, I have to turn around and go back to where I started from to remember what I was going for. That's a very typical example of normal aging memory loss. Normal aging memory loss, when people that experience that find that they may have a harder time multitasking. It may take longer to learn more information. The next category of memory loss is mild cognitive impairment. And mild cognitive impairment is when people are forgetful and it's noticeable to others. The incidence of mild cognitive impairment is about 12 to 18% in people over 60. People with mild cognitive impairment, you can be forgetful, forget details of conversations, but able to manage the business of your life. So able to manage your finances, able to manage your appointments and schedules, able to manage your medications, maintaining hobbies and social activities. But it's important to identify if you actually do have mild cognitive impairment, because of that 12 to 18% of people over 60 that have mild cognitive impairment, we know that there is a certain percentage of those people that will progress to dementia. And the definition of dementia being that forgetfulness and memory problems are severe enough that you have difficulty maintaining those complicated things in life, like finances, driving, medication management. Approximately 10 to 15% of people that are diagnosed with mild cognitive impairment will progress to dementia. So it's important to identify if someone has mild cognitive impairment. Now, many clinicians feel that diagnosing mild cognitive impairment isn't really very important because there aren't any particularly effective strategies for treatment of mild cognitive impairment. They feel you can't reverse it, you can't change it, but that actually is not true. There are definite benefits to identifying and diagnosing mild cognitive impairment. Mild cognitive impairment could be due to another medical problem that can be treated and potentially reversed. There are many things that can affect memory: depression, sleep problems, metabolic disturbances such as thyroid problems. So it really is important to get evaluated if someone has mild cognitive impairment or is having memory problems. If in fact you are identified to have mild cognitive impairment, it is very helpful for family members, because one of the typical things that people will say of a family member, a spouse, oh, well, he just doesn't listen to me. He's ignoring me, or he doesn't pay attention. But if someone has mild cognitive impairment, they really may have amnestic short-term memory loss, and they're listening, but they can't remember. So it can really help to reduce relationship stress, to identify that, yes, this is really mild cognitive impairment. If someone is diagnosed with mild cognitive impairment, that is an excellent time to start your future planning. And of course, I'm a big advocate for advanced care planning and advanced directives, estate planning for any older adult. But anybody that's diagnosed with memory problems, this should be a priority. So those are the biggest reasons to get a diagnosis. And if you're concerned, talk to your primary care. And, one of the things that can be very helpful to start identifying is your annual Medicare wellness visit, because that includes a screening for cognitive impairment. I'll be happy to answer any questions, and thank you very much.
No, thank you, Vicki. So I know a question that comes up a lot that I hear, particularly from families, is what's the difference between dementia and Alzheimer's and MCI, and how do you differentiate those things?
That's a great question. So dementia is that big overall umbrella term that the different types of dementia fit in that umbrella. So you can have dementia of the Alzheimer's type, or there is vascular dementia. There's Lewy body dementia, there's alcoholic dementia. So the definition of dementia, again, is memory problems that are significant enough that impair the complicated tasks of life. So that's the dementia. Now the causes further define the type of dementia.
Wonderful. Thank you so much, Dr. Armstrong. I see that we have a question, and what we're going to do that was submitted. And again, I ask all of the attendees, if you have questions for Dr. Armstrong, any other of our panelists, please submit them through the Q&A box, and we're going to get to them for the second half of our panel. So I promise you we will get to that. I see Nancy Conta, really, really good question, and we're going to get to that here shortly. But I would like to turn to Dr. Purdy, our expert pharmacist here on the panel. She was submitted some really interesting questions that would love to hear her address. And Jennifer, if you wouldn't mind stating some of the questions that were submitted to you. I'm sure you're doing that on your slides already. And then, yeah, let's hear some of your great information here.
Okay, yeah, definitely. Can everyone see my screen, my slides? Yes, okay. Yeah, so I went ahead and prepared just a few slides for us to go through. Most pharmacists are a little bit OCD, so it's a little bit of that going on here. I also had a lot of information that I wanted to cover. So this is going to keep me on track, and then you have that information available to you should I talk a little bit too fast. So some of the questions that I wanted to address today, I wanted to talk a little bit about Atticanumab, which is the new Alzheimer's disease medication. I wanted to spend a few slides talking about psychotropic medications. Specifically, we're going to talk mostly about antipsychotics. And then I'm going to do a little bit of shameless self-promotion and talk about a comprehensive medication review and geriatric assessment. So first, let's talk about Atticanumab. Again, this is the first new medication for the treatment of Alzheimer's disease that's been approved in about 17 years. We do have a couple medication classes that are out there on the market right now, and really they have a moderate benefit at best. So it's very exciting to see something new coming to the market. This is a medication that was approved under an accelerated pathway using surrogate endpoints. So what does that mean? So sometimes the FDA, if they see that there really is a lack of good treatment for a disease state on the market, they will allow a medication to come to market a little bit sooner using surrogate endpoints, in this case, amyloid plaques in the brains, to allow patients access to that medication earlier than what we would normally see. So the drug company Biogen still has to provide the clinical data on this medication. In this case, they have until 2030 to do that. But with this accelerated pathway, it's available to some patients that it may be beneficial for. I will say there is a lot of potential issues with the way this medication came to market. It's been criticized and it's currently being investigated. The two trials that were done didn't really show any great benefit and were actually stopped early. And then there was sort of a secondary analysis that potentially showed some benefit. There were some people that resigned their posts at the FDA because of the way this medication was approved. So definitely more information is needed on this medication. I did want to mention that this is only approved for Alzheimer's patients with mild cognitive impairment or mild dementia. So this is really for the early stages of Alzheimer's disease dementia. It's not approved for later stages. And as Vicki mentioned, all the different kinds of dementia that there are, this is not a medication that is approved for any other type of dementia. There are some significant side effects that we have seen with this medication, greater than 10%. So that's a pretty high rate when we're talking about medication side effects. So things like brain microhemorrhages, which are small bleeds, or edema, which is the accumulation of fluid in the brain. So because of these side effects, if someone were to go on this medication, not only do you have to have a brain MRI at baseline, but also twice more during the course of therapy to ensure that these side effects are not occurring. This also is not going to be a cheap therapy. It's expected to be about $56,000 per year. There are several insurance companies out there that have already said they're not going to cover it at this point. So there's still some question about sort of the benefit versus risk of this medication, but certainly I think the fact that it's out on the market and accessible to maybe some folks that there could be benefit for is exciting. And hopefully we'll get some good data on this medication in the coming years. So again, this medication's for kind of earlier on in the disease process. Next, I wanted to talk about psychotropic medications, specifically antipsychotics, which we tend to see used later in this disease process. So psychotropic medication, just to give you some definitions, it's really an umbrella term for any medication that gets into the CNS and can affect your mood or mental state. So that includes antipsychotics, and then things like antidepressants, anti-anxiety medications, things like that. When we're talking about antipsychotic medications specifically, I gave you a few examples there of some of the most common ones that I see used in this population. And typically when we're looking at these medications, we're looking at them for the behavior and psychological management of symptoms related to dementia. So most commonly, you'll see things like agitation, wandering, aggression, hallucinations or delusions. A few key points is that if we're using these medications to manage hallucinations or delusions, they should be distressing. If someone is having an hallucination and maybe it's something that they find comforting, we don't need to treat that. This is for something that is really bothersome to that person. We can also use these medications in patients with that agitation or aggression where it's to the point that they are a risk either to themselves or to others around them. Reversible causes of any of these symptoms should be ruled out before we're using these medications. And of course, non-medication interventions, as any of my other panelists will tell you, should be tried first. And really, these are things that are continued through the course of this disease process. They're not one-time things. And we'll talk a little bit more about that on the next slide. Also, before we're looking at antipsychotics, we should be using other medication classes where appropriate to manage some of these concerns that happen along with dementia. So things like depression or problems with sleep are often better managed with other medication classes along with some non-medication options so that we can avoid use of these medications when appropriate. So some of the non-medication interventions that should be tried first, and this is just really a small example of some of the things that can be done. There's many, many more, but I wanted to mention a few. So things like music therapy, so listening to whatever music that person enjoys, physical therapy or exercise, just getting outside, going for a walk. Eliminating physical discomfort or pain. So oftentimes someone with dementia may be agitated because they're in pain and maybe they can't express or explain that pain, but they express it as being agitated. So making sure that we're addressing those kinds of things. Some of these are things that you as the caregiver can do. I don't often like to compare patients with dementia to children, but this is one case where I think there's where it works in both groups. And I think of my 4-year-old son. If I'm talking with him and I'm making sure I'm being positive, I'm explaining clearly, I'm demonstrating where I need to, he's going to respond a lot more happy and appropriately that what I'm looking for. So again, I don't like to make that comparison very often, but this is one of the few things where I think the demeanor that you have and that you express with your loved one, with that person that you're caring for, can go a long way in helping to manage some of these symptoms. It's not perfect, but it can certainly help. So if we've kind of tried all these other interventions we've talked about, we've tried other medications, we're at the point where we feel an antipsychotic is appropriate for this person. There's a few standards of care that we're going to follow. One of the things we talk about in the care of older adults often is start low and go slow. So that means we're going to start with the lowest dose possible. Oftentimes that may be half of a tablet, and increase that dose slowly to the appropriate effect. And that's going to vary from person to person. When we give an appropriate, adequate dose trial of these medications, so not just the starting dose, but if this person has reached an appropriate dose, and again, that's going to vary, but we're not seeing any benefit, we'll give them about 4 weeks. If there's no benefit, this medication really should be stopped. It's not having the effect we want it to have, let's get rid of it. In those patients or folks that have a good response to these medications, we've reduced hallucinations, we've reduced agitation, whatever the case may be. Even in that population, we would look to reassess that medication in about 3 to 4 months. And we would consider either decreasing or stopping that medication. And there's a couple reasons for that. So one is the disease process itself. These symptoms of agitation tend to kind of have a peak and then they wane off, excuse me. So they're not consistent. So it's appropriate to kind of reassess this every quarter or so to make sure that this medication really still needs to be continued. The other reason to consistently reassess these medications is there is risk associated with these medications, and that's the bottom of the slide I have here. So some of the side effects we can see with these medications, things like orthostatic hypotension. That is a drop in blood pressure that happens when you have a level change. So if I were to go from sitting to standing and my blood pressure drops, that is orthostatic hypotension. As you could imagine, that puts you at a much higher risk for falls. Things like anticholinergic effects. This is my bread and butter as a pharmacist in this population. So anticholinergic effects, you can kind of fit into 2 categories. On one side, we have what I would consider the drying side effects. So dry eyes, dry mouth, urinary retention, constipation. Could be bothersome, but somewhat manageable. Then on the other side, the things that are maybe a little bit more worrisome, things like sedation, things like cognitive impairment, which if we are managing this population with cognitive impairment, you could see where that would be an issue. Things like QT prolongation, which is a cardiac arrhythmia that can be deadly, and then cardiovascular events like a stroke. And that's really where this black box warning comes in. And it's sort of a heavy statement, but I'm just going to read it to you. So elderly patients with dementia-related psychoses treated with antipsychotic medications are at an increased risk of death. Again, heavy statement, right? So let's put a little context around that. So we know that over the course of about 8 to 12 weeks, if we treat 50 to 100 persons with dementia with these class of medications, we will have 1 excess death. So there is risk with these medications. And I don't share this to scare you. I share this and all of this information to provide education so that if you are considering these medications, you sort of know what should be tried first, what alternatives are out there, and then when we're using these medications, what principles we really should be following to ensure that the benefit outweighs the risk. That's always what we're worried about with medications and really any therapy. Does the benefit outweigh the risk? Okay. Lastly, I wanted to talk about the comprehensive medication management that a pharmacist can provide in this population. So there's various different terms you'll see in lots of different abbreviations, CMM, MTM, CMR. Again, that probably goes back to that OCD thing. The great thing is if you have Medicare Part D or a Medicare Advantage plan, you may be eligible for this through that insurance. So it's worth, talking with your pharmacist, especially if you have a pharmacist that you have a good relationship with already, to see if you qualify for this service. And again, the best thing is it's at no cost to you. The insurance, it's a service that they provide. That pharmacist that you sit down one-on-one with should review all of your medications. And really the overall goal is to optimize therapy. You would walk away with an up-to-date medication list and an action plan. So if there's any changes that the pharmacist sees that need to be made, that would be in that action plan. Again, here's the shameless self-promotion part. So I wanted to talk a little bit about the comprehensive geriatric assessment that we do here. So I think the great thing about the work that we do here and that Vicki does and all of the team is we get to work with other disciplines. So it's not just the pharmacist looking at your medications. It's not just your primary care provider trying to manage everything. It's all of these different team members that have their own expertise that really get to come together and provide what I think is the best care possible. So for my component, when I'm looking at that medication review, I'm reviewing everything. So not just prescriptions, but herbals, over the counters. I think sometimes there's a common misconception that because a medication is natural, it's safer, or because it's over the counter, there's no real risk there. And that's not the case. One of the most common things I see is Benadryl being used as a sleep aid. That's that anticholinergic side effect that I mentioned earlier. That medication is highly anticholinergic and can, again, cause that cognitive impairment, cognitive issues, and can really negate the benefit of some of the other Alzheimer's disease medications that we use. I would provide education not only to that patient, but to the caregiver as well. We get to follow up with the providers to provide recommendations. Often the focus is deprescribing or getting rid of medications. That's not always the case, and it depends on the goals of that particular person sitting in front of me. But 9 times out of 10, I'd say we're looking at trying to simplify therapy. And of course, we would follow up. Great thing about being followed in the clinic is you get that follow up. We get to assess how you did with those changes and get to keep working and further optimize therapy as much as possible. Okay, and that's all I have.
Wonderful. Thank you so much, Dr. Purdy. That was a great presentation. A reminder to the attendees, definitely, if you have questions that are coming up while you hear our panelists present, please do submit through the chat or Q&A functions on the bottom of your screen. And again, we're going to get to those here shortly. We also will be sending a copy of the recording as well as the slides to you after this presentation as well. So I'd like to turn to Chaplain Greenman next, please, to have her address some of the questions that were directed to her, and looking forward to hearing about that. So thank you, Chaplain Greenman.
Thank you. I had 3 questions, the first of which is about dementia and spirituality. And of course, spirituality is the desire for meaning and purpose. Spirituality is related to one's connection with self, with others, with nature and the world, and with the sacred, which to the religious is, of course, God. But spirituality is integral to, but not confined by, religion and faith. And spirituality in a person living with dementia can absolutely flourish. Feeling spiritually alive is not dependent on cognition. Jennifer Butte, a physician who had dementia, wrote, "It can be a positive journey. It appears that the spiritual being remains true to the end and does not degenerate in the same way as the brain, so I can still show love and care." Next slide. We can support our loved ones with dementia by walking in nature. Very often, being in nature, seeing a deer, walking amongst the trees, a rainbow, a kitten, a puppy, helps one feel spiritually alive. We can help them to help others. Frame it as a request. Say, well, you know, the animal shelter has lost funding. Will you help me make dog biscuits and we can deliver them to the shelter? I sure could use your help. Arts and creativity and music. Music and song lyrics live in a different part of the brain, and so they're retained longer. And music touches our emotions and our deep memories. Initiating rote prayer. If we hit that start button for them, it's amazing. Very often, even non-speaking people come up with the right words and spout out the Our Father or the Rosary or John 3:16, or I sing I Come to the Garden Alone with all the words. Often putting something in their hands, like a stethoscope for a physician or wool and knitting needles for a knitter. The wife of a gentleman who had refurbished hundreds of gloves for underprivileged kids put a baseball glove in his hands. And that was so comforting for them. They may not be able to verbalize their memories, but it seems to bring their comfort. And when they can't talk about their accomplishments and their legacy, this is a way to, as Jolene Brackey says, remind them of their greatness. Next slide. As the disease progresses, a person living with dementia can become a little bit disinhibited, and so they don't do well in large crowds with lots of things going on. So other options include a weekday service with a smaller crowd or a streamed service. Lots of churches before the pandemic in the area had what they call dementia-friendly services, and I hope they restart them soon. Or just go to the church or the temple, sit by the stained glass window, light a candle and sit in that space. Just sit in that space a bit. Next slide. I saw a video of a person in late stage who was wheelchair bound and no longer able to communicate verbally, but he was able to participate in a drum circle, and that helped him to feel spiritually alive. He had a big smile, and everybody else in that drum circle had a big smile and had a great time. Very often, when you do these sort of things to help your loved one connect with their spirituality, you're going to connect with your spirituality too. Christine Bryden is a person living with dementia, and she wrote, "We can connect spirit to spirit, even at the last stages. As our cognition fades and our emotions flatten, our spirituality can flourish as an important source of identity." Next slide. Next is about caregiving and guilt. Caregiving has so many rewards, but even with all the time and energy caregivers put towards caring for a loved one, caregivers of people living with dementia often carry around undeserved guilt. Very often this occurs when you're doing something fun, something to take care of yourself, something to feed your soul. Often I've heard caregivers of people living with dementia say when they're doing something fun, they feel guilty and sad that their loved one is not there and cannot enjoy the experience. Well, Dr. Natalie of Careblazers says, when you feel sad and guilty, having fun when your loved one is not, remind yourself, and I quote her, "No amount of suffering helps your loved one with dementia." Tell yourself, I don't have to suffer 24/7 in solidarity with my loved one. It doesn't help them and it doesn't help me. And then be mindful and present to your fun activity and fully enjoy it. Caregivers sometimes feel guilty about having negative emotions, about having unreasonable standards. They feel they're not a good enough caregiver, or for getting help, they think they should do it all themselves. You all can probably tell me lots of reasons you sometimes feel caregiver guilt. Next slide. So what do you do about it? Well, first you acknowledge the feeling of guilt. Then I highly suggest you join a support group, online or in person. You're going to find out you're not alone at all in feeling caregiver guilt. Give yourself some grace. No one can be a totally selfless servant. Take care of yourself. Sometimes when you practice a little self-care, you may find some of those feelings of guilt just dissipate, they go away. Check your expectations against reality. We often have unreasonable standards for ourselves. Nobody is perfect. In our support group, we often remind each other, well, yeah, you did snap at her, but you know what? She's got short-term memory loss. She's forgotten about that. It's gone for her. So stop agonizing about it long after she's forgotten. It's not helping anyone. Let it go. Also, then just remind yourself of the positives. Remember all the wonderful times, the good visits, the good choices, all the good things you've done for your loved one with dementia. I'm a big fan of positive self-talk. Next slide. They asked me, one question was about dementia end of life, and this is really hard to talk about because it's very sensitive and I don't know your situations. But one thing it's important to know is dementia is a terminal illness. People die from this disease. So you need to do all the things you would do if you were given a terminal cancer diagnosis or any sort of diagnosis like that. Please discuss, as Vicki said, your end of life plans with your loved ones as soon as possible. If you can, as soon as your loved one is diagnosed. Even though it's probably a long way off, people can live with this disease for 20 years. I've read the average is 8 to 12 years. And at first it doesn't seem that important because they're doing well, just a few memory issues and a few bumps in the road, but the disease will progress and you want to have your loved ones input about what they want at the end of life and throughout the disease. It's not like you need to think about this all the time for the next 8 to 12 to 20 years of living with dementia in your family, but you do need to face it and get these conversations done. And once you've had these discussions, made your decisions, and informed your whole family of your plans, that's vital. You want the whole family knowledgeable and on board with the plans to help prevent potential family conflict later on. Well, then you can focus, can become living life as fully and well as possible. Next slide, please. So as Vicki said, get your things in order. Complete your advanced directives, which lets you know, writes down what your loved one wants and doesn't want at end of life. And it also lets the people know who your healthcare advocate is, who will be making choices when they can't make choices. Might as well do it for both of you. Complete the post form. That's the physician's order scope of service form. It evokes the advanced directives by making them a doctor's order. Decide upon death arrangements, such as do they want cremation or burial or scattering or giving their body to science. Decide where you both want to be buried or scattered. The details of your memorial services. You probably know what you hate at memorial services. So write down what you don't want. Write down the hymns and scriptures that you'd want if you know what they are. Your pastor can certainly help with this. Of course, pre-plan with the funeral home. And if you really want to be kind to your loved ones, go ahead and write your own obituaries. Now, as the disease progresses, when your loved one's ability to remember and to think and to speak is diminished, you will be making a lot of decisions all along the way. So it's really great if you understand the progression of the disease, because if you understand when they are in the late stages and nearing those last months of life, most people would weigh healthcare options differently than they would in those earlier stages of the disease. Next slide. Your doctors, nurses will be able to assist you in knowing when it's time to call hospice. And if you think your loved one is in the late stage of dementia and your doctor has not mentioned hospice, please ask them about it. I highly recommend that you get hospice involved as soon as possible. They are good in the last weeks or days of a person's life, certainly, but their help really shines if you have hospice several months before a death. They can be a part of your team for the last 6 months of your loved one's life. The hospice team, along with your physicians, can guide you. They can talk through and help you make decisions, and they can give you and your loved one emotional support all along the way through the last part of this disease. Next slide. You know, some things that are wonderful for lots of patients, sometimes they just don't do well in people in end-stage advanced dementia. For instance, feeding tubes. Having a hard time eating, pocketing food, swallowing, having a hard time swallowing is common in late-stage dementia. Lots of times they'll just stop being hungry or wanting to eat. However, the Alzheimer's Association points out there is, quote, no proof that tube feeding extends life or has significant benefits, unquote, in a person with late stage dementia. Tube feeding can result in the need for physical restraints. Over 80% of the people living with dementia are trying to pull them out, and it's so uncomfortable and so miserable for them. So ask about the benefits and costs and risk of every treatment or intervention or trip to the hospital, especially when you understand your loved one is at the end of this disease. Ask exactly, how is this going to improve the quality of my loved one's life? Next slide. It's important to understand not offering tube feeding or antibiotics or CPR is not the same thing as euthanasia or assisted suicide. It is supporting the person's dignity and comfort and letting the disease take its natural course. Be assured the hospice team and the medical team can provide good physical care and emotional care for you and your loved one, as well as ensuring your loved one is not in pain and is as comfortable as possible. One of my regrets with my mother, the nursing home called and said she was in an ambulance on the way to the hospital. I went to meet her and they discovered that mom had pneumonia. So they started her on IV antibiotics and she was in the hospital for 3 days getting IV antibiotics. Well, looking back on the few months that she had after that, which were absolutely horrific, she suffered so much those last months. I realized if I had not agreed to the antibiotics, she could have had a peaceful death, been kept comfortable, and I could have helped her prevent those couple months of suffering that could have been avoided. Next slide. Now, during the absolute last days, a lot of families, what I call hold vigil. Holding vigil is when the family gathers and takes turns to surround their loved one with love and peace in their last hours or days. Well, Ira Byock says there are 4 things to say at this time, and we all find our own way of saying these things, but they are, I love you, thank you, I'm sorry, I forgive you, and finally, tell them goodbye. You can go home. Now, your father with dementia might not finally tell you he is proud of you, and you've longed for him to say that your whole life. Your loved one may not reconcile with you the way you'd like. However, perhaps you can tell them that you forgive them, that you are sorry, and that you love them, and they will hear you. It is healing to speak these words, even if your loved one can't respond. Now, some families don't hold vigil, and some people feel guilty if they aren't there the actual moment their loved one dies. Please let go of that. You know, you were present and loved them a whole lot of days, weeks, months, years besides their last day. And that last day just doesn't weigh more than all those other days. You've probably been grieving a lot along the whole way by this time. We call that anticipatory grief. But at the end of your loved one's life, there will be so many changes in your life, not the least that your role as caregiver will change. And that's a pretty big deal. Consider journeying through the process of grieving with a good grief group. Traveling the journey of dementia is not an easy road. There are many rewarding, wonderful, life-affirming experiences along the way, and lots of times of tears as well. But through it all, I urge you, be kind to yourself. Thank you.
That was just wonderful. Thank you, Chaplain Greenman. Really, really appreciate that. I know Dr. Jensen had a specific question for you. Christy, did you want to ask the chaplain something?
Thanks, Joe. And I know we have, Joe, I just was monitoring the Q&A and we have some terrific questions that have come in for all our panelists. So I know after we hear from Dr. Fox, we'll get to those. But Chaplain Greenman, I was working with a family and a comment you made, I'm wondering how I can be of help to them, would appreciate your input. You made a comment about reaching out to your pastor or minister or priest to get some help with some end of life planning or how you might want recognition or a memorial service. And this family that I was working with didn't have an identified church or religious organization or even specific faith. And so they didn't have a faith leader to go to. What would you recommend? But I got the sense the family wanted to do something and they were starting to think about how they could recognize their loved one. What would you recommend for them if they don't have that kind of community already or connection?
Sure. Well, they have their social relationships and people who can gather, and they can plan any sort of memorial or legacy or things. There's a lot of non-faith things that you can do that aren't in church or temple to honor and remember a person in different ways of gathering. Gathering and sharing stories, making memorials, gathering and everybody sharing stories and light a candle. You can make it pretty formal. They can call me. There's a lot online. Many times the funeral home can help. They have a little chapel there, and that's a nice place to gather. So there's lots of things you can do without a church if you don't have a church community. But if you do have a church community, and your pastor can probably really help you walk right through it.
Very good. Thank you so much for that.
Yeah.
Wonderful. Very exciting. Again, really appreciate the questions that have been submitted up to this point. Again, I encourage all of you attendees, please feel free to use the Q&A box to ask any questions that you might have now. And again, we're going to be getting to those probably after we hear from Dr. Fox, who's our next panelist. Dr. Fox, please.
So today I will be going over some different strategies for facilitating activities of daily living with your loved ones. So activities of daily living are going to include helping them with their toileting routine, getting dressed, showering, bathing, making sure that they can eat a meal. And then we'll talk about some different communication tips, and then we'll look at some support services and home modifications that can be helpful. So how do we help our loved one with dementia feel useful and successful every day while they're doing their ADLs? It's important to provide choices and also to work to connect with them on an emotional level. Often using prompts. A prompt may be a verbal cue. You may also just bring in the item that they're going to use, whether it be a hairbrush or a toothbrush, or putting a plate and the silverware on the table. Those are all examples of prompts. Sometimes even a picture of them brushing their teeth posted in the mirror in the bathroom can be helpful, so that when they see the toothbrush laying on the countertop and they see that cue, it gives them an idea what they're supposed to do with that tool. Also, written notes can work. You can do written schedules, like my morning, routine. You can laminate it and then use like a dry erase marker and have them go through and follow it in some of the earlier stages. And then it's also important to tap into their long-term memory. Often short-term memory, goes first, but you can use that long-term by reminiscing, whether it be using an antique hairbrush or their favorite vinyl album. A lot of times pictures are used, but you can use any common day object that's located in your household as well. When you're guiding them through, an activity of eating, getting dressed, bathing, it's important to guide through that activity and to let them know what is going to happen in advance. So, Mom, I'm going to help you wash your back. Okay, will you wash the front of your body? Okay, next we're, kind of give it step by step, so they know exactly what to expect. Even simple things of, we're going to test and see if this water's warm enough. Let's test it on your toes first, that kind of thing. And they are going to need an extra time to complete these activities, getting dressed, brushing their teeth, even just waking up out of bed. Sometimes they might need a little bit of extra time. So being patient, trying not to have your time management to the point where you're having to rush them through those activities, because that can lead to frustration on their part and also for you as well. And one of the things that I feel like has been very important so far with this webinar is taking a time to understand where, if your loved one has a mild cognitive impairment, where are they on that scale? So I really like the functional assessment staging scale, because it gives you an idea of, you might have no cognitive impairment at that first stage, a little bit in that second stage, but when they start to get to the fourth stage, they're needing a little bit more assistance with managing their medications, managing their household. And this is often when they're first diagnosed. It becomes more apparent to family members and friends. When they get to that fifth stage, they're going to need a lot more help with getting dressed on a daily basis, brushing their teeth, making sure that they're doing, maintaining their toilet hygiene. And, if they may start to struggle with incontinence, how do they manage that process then? I like the idea of kind of thinking the strategies that you would use with someone who's 5 or 7. It's important to kind of take note of that, because how you would interact with someone in that age period is very different than how you would interact with them if they were full, healthy adult who was 62 years of age. As they progress to that 6th stage, this is when they are going to need 24/7 care. They are more dependent for all of their ADLs. And by the time they transition to that 7th stage, before they pass on, they are needing significant assistance. They often are completely dependent for all of their ADLs. Their communication is going to often be more and more difficult if they even have the ability to communicate, that it remains. And their mobility decreases significantly. They may be predominantly confined to a bed or into a supportive chair. So kind of getting an idea of where they are on the stage will help you with how you interact with them and what strategies you use with them. So when communicating with your loved one, it's important to take note of their sensory needs. So often as we age, we have a harder time being able to hear things, see things. And so looking at the volume that you use for your voice, the speed in which you provide cues or ask questions, making sure that their personal hearing devices are functioning and working. I've worked with numerous families where they have hearing devices, but they don't like the way they fit and they don't wear them. Or they don't know how to change the batteries and they need assistance with that, every other day. Even little simple things of reducing noise distractions in the environment can go a long way. Are you trying to have a conversation in the noisiest room of the home or in a busy hallway? What we say and the words that we choose are only a part of the message. It's important to take note of our body position, making sure that we come down and we're at their eye level. You know, a lot of times as we age, we start to have difficulty with our neck range of motion. So if someone's standing over top of you and you're not able to move your neck to meet your eyes, you're stuck in this awkward, I'm trying to meet their eye gaze and I can't quite, and I'm getting frustrated and I don't know why. So making sure that you're close enough to them so they can see your facial expressions. I really like to be in the center of their visual field, and also check your own body language. Often they can mirror the body language that they're seeing in you. So if your hands are like this, they might think they're mad at me. Why are they mad at me? So making sure you have an open body language. As they progress through those stages, their communication and their ability to determine, you know, what they want, if they need to use, if they're cold, hungry, if they start to get, if they're starting to struggle with, I have to go to the bathroom or I have this urge and I can't quite communicate with that. Often you'll ask someone, say, do you need to use a restroom? They'll say no. But as soon as they stand up and they start moving to the bathroom and they see the commode or they hear running water, that answer will change. You can also, it's important as you kind of look at, because people go through the back end of that bell curve cognitively, the strategies you're going to use is changes. So you want to have a good understanding of what are the things that calmed and soothed them at different parts in their life. So what were some things they did to self-soothe when they were 12? How about when they were 5 or 7? When they were between the ages of 2 and 4, or when they were, 12 months or younger? As they get closer to that, the infant ages, they're going to have more difficulty with communicating. Often their mobility drastically increases, and you may be using more sensory strategies at that time. So music, sound, taste, and touch. And then often this is something that is incorporated into our culture. We use honey, sweetie, and dear. It's important to make sure that we are using their names and their preferred names. So if we don't, if they're not our loved one, we're using a formal Mr. Jones or Mr. Smith, and not using we or our when we're working with them through those activities of ADL. So Mr. Jones, are you ready for the shower? Yes. Or Mr. Jones, sometimes people might say, we are going to go do this. Let's go. You're not giving them a choice. You're not recognizing them as an individual. So that can cause increased frustration because they may not feel like they're being recognized and they can't communicate that. Here are some things to avoid. Don't ask short-term memory questions. What did you have for breakfast? What did you do this weekend? That can instantly lead to frustration. It's not worth it to try to ground them in reality, and arguing is not going to get either of you anywhere. I think the most important thing to take away with when you're working to improve communication with your loved ones and those with dementia is they may not always remember what you said, but they will remember how you made them feel. Sometimes, though, you will have difficulty. You have to communicate something that they don't want to do or they're not interested in. So you can use distractions. It's important to validate their experience, their truth, and their feelings. You can prevent things from occurring, maybe, or simplify a task, reducing the type of choices that they have to make. Maybe you want coffee or tea for breakfast. And we're human. We're going to make mistakes, and it's important to apologize when we do. I'm so sorry I shrunk your compression stockings. I forgot to pull them out and let them hang dry. That is my fault. I will go get you another pair. These strategies don't always work, but sometimes it's best to just step out, do something for yourself to help calm and soothe you so that you can kind of leave that frustration, toss it over your shoulder, walk back into that room, and then try again as if nothing happened. So often, we'll have people as they progress through those stages, they're going to need different levels of services and support. So often services and home modifications are prompted by multiple hospitalizations. So someone may have been in the hospital system 2 or 3 times within the past 3 to 4 months. For me as a therapist, that's a red flag that obviously maybe their cognition, they're progressing to a different stage, or their environment may not be adequately set up to be able to provide the support that they need. Safety in their current environment, are they wandering and getting lost? Are they starting to have increase in behaviors? Are they at risk of injury to themselves or others, whether it be accidental driving accidents, or perhaps burning themselves while they're using the stove in the kitchen? Or are they struggling to manage, incontinence problems? Often these supports that'll be available, you can have some that are available in the home, but then we also have some that are outside the home as well. So home health therapy is often available when someone has entered the hospital system and they need a little bit of help getting better. It's just something to remember. This is not a long-term solution. Typically the home health nurse and therapist will come, and it'll be for a short period of time. There are some cases where they may be there for maybe more than a couple of months, but it's often typically a short visit. If you need more long-term care support in the home, you're looking at private duty aides. Environmental modifications, we'll take a good look at this, what this means with a picture in just a moment. And then also durable medical equipment. So these are things that can help improve their safety in the home. So here we have a shower. Before it was modified, you can see there was a tub they had to step in, a fixed shower head, a very low toilet, and a sink that's a little bit hard to get close to it. And then you can see now with the modifications, it's now completely wheelchair accessible. You have an elevated toilet seat, there's grab bars, and a detachable shower head, and everything is tiled. So if there are any accidents that occur, they're a lot easier to clean up. And then here are some mobility devices on the right-hand side. There's a standard wheelchair, a front-wheeled rolling walker, and a rollator, as well as a quad cane, a shower chair, and then a 3-in-1 bedside commode. So there's also services that are available outside of the home. As your loved one's needs, they may need more assistance with ADLs, they may have more difficulty communicating their needs, and they just can get to the point where they're not safe to be home alone. So you have assisted living. There's different levels with assisted living. So some of them will use mechanical lifts if your loved one needs to be able to do transfers and to move from point A to point B. Some of them have to be at an ambulatory status. So when you're looking at different facilities, it's important to see what can they accommodate as your caregiver's needs change. There's memory care services, adult day services, and then long-term care when they get to the point where they are dependent for almost all of their ADLs and need mechanical lifts and 24-hour nursing care.
Excuse me, Jackie, I'm not seeing your slides. I know that you're talking about a couple images that you're showing.
Oh, okay. Let's see. Thank you for bringing that to my attention.
There we are. Perfect.
There we go. So here is the picture of the environmental modification for a bathroom. You can see that they have the walk-in tub. There's not a lot of room to be able to navigate around, especially if you consider you may be using a wheelchair or a walker or a rollator. And then now it's wheelchair accessible. And then over here, these are different pieces of mobility devices, shower chairs, and a 3-in-1 bedside commode. These are some of the different outside services: assisted living, memory care, adult day. One thing that's really important is when you start looking at, providing services for your loved one, whether they be inside your home or outside of the home, is to look at, it's always best to have the least number of moves. Every time someone re-enters the hospital system or they go to a skilled nursing for rehab, they may decide to family to transition to assisted living. Every time they move, they are at risk of suffering transfer trauma, where they can have increased agitation and confusion, and they can have a hard time adapting to a new environment. When people start to have that mild cognitive impairment, that is when it starts to be difficult to move or to experience novel learning. And whenever you move to a new setting, that is going to occur. So as family members, try, if you can have the least number of moves, that will be helpful for them in the long run. So today we took a look at some different communication tips. It's important to be patient and realize that improving communication is a process. You won't always get it right. And sometimes you might need to step away and come back and reapproach. Home modifications can help improve safety in the home for a period of time. However, when their ADL needs and their communication deficits continue to decline a little further, you may need to look at some of those external supports outside of the home, such as assisted living, a memory care facility, maybe adult day services when you're at work. And then the most important thing that I feel like all the panelists have already touched on today is that it's really important to remember that they may not always remember what you said. Often they may forget it 15 seconds, 30 seconds, 2 minutes later, but they will remember how you made them feel. So when you're working to communicate with your loved one, it's important to connect with them. Drawing on their long-term memory is a great place to start. Thank you.
Wonderful. Thanks so much, Dr. Fox. We just have a number of great questions that are being submitted here. Quick logistics here before we get to answering some of the questions that have been submitted by the audience here. Yes, we will be providing you a recording of this panel as well as all of the slides, and we'll be sending that to you in the week or so after the presentation. So thanks again for asking that. I think we should just go right to some of these questions that have been asked, and let's start with a really good question from Nancy Conta. And I'm going to direct this to you, Dr. Armstrong. Vicki, in your opinion, is there an optimum time in the disease to transition a person with Alzheimer's from family care to a facility?
That is a really great question. And the answer is that it depends on the individual. Because there are many people that we talk to and the caregiver says, well, I would never consider placing in a facility, but then something happens and that changes. They find that they, whatever that person's care needs are, they can't meet them for whatever reason. So that is the time when it is time to consider some kind of assistance or facility. And that can change. It can change on so many factors. Maybe the caregiver has a change in their health status. That's one of the things that can happen. And then sometimes people will say to us when we initially meet them, if incontinence becomes a problem, then that is probably when I would consider placement. But then incontinence does become a problem and they say, it's not that big of a deal. I'm managing fine. So it really is, it's such a dynamic process to make that decision. So I hope that answer helped you, because it's definitely not a cut and dry answer.
Yeah, that's a great way to put it, Vicki. There is no right or wrong time to make this decision. It's so personalized. It depends so much on the needs of the loved one. It depends on the family caregiving context and how the family or the care system is dealing with the situation. I shared in the chat, and I don't know if you'll find this helpful or not. We've used this with some of our families. A lot of our research focuses on, or some of it anyway, focuses on helping families navigate this transition to residential long-term care. And some of our interventionists have used what are called decision aids to help with this. So I'm going to share my screen and show you one. This is one that we have found very, very helpful in the past. And let me pull it up here. This is by HealthWise. And again, this is in the chat. And what's nice about this is, usually when you're making this decision, there's so many emotions around it. I mean, there might be feelings of guilt, feeling that, I never thought I would, put my mom or dad or husband or wife or partner in a long-term care setting. And, what's nice about a decision aid is it helps somebody kind of lay out the pros and cons, the challenges, opportunities of the decision in a stepwise way that sometimes when you're just trying to deal with such a monumental decision, it can feel really overwhelming. And so when you go step by step through this aid, it talks about your feelings, your decision, quizzing yourself. It then provides you a summary to give you a better sense of where you're actually at. Now, again, as Dr. Armstrong mentioned, it's not an end-all be-all answer. The answer changes depending on the day, but at the very least, the decision aid could kind of help separate out for you or others who are making the decision. What are the pros and cons? What are the resources we currently have? What are resources we don't have? And would a decision to admit a loved one to residential long-term care help meet us where we're at? So again, that's in the chat for you. And hopefully, and I included not just this one, but several other good ones I found. The Mayo Clinic has some good ones too, that hopefully you may find helpful if you're dealing with this decision or someone else is trying to deal with this decision as well.
That's great. Thank you very much. It is a good tool.
Great, Vicki. Yeah, hopefully you can use it too with people if you find it helpful.
Absolutely.
Great. Dr. Purdy, I'm going to direct this next one to you. My mom is on the strongest form of memantine. What is the next recourse because her memory is getting worse with her dementia? Should I ask the pharmacy for another evaluation, or is there an alternative to medication?
So currently on the market, there's really two classes of medications that we commonly use for Alzheimer's disease. Memantine is one of those, the other one being cholinesterase inhibitors. So most commonly that's donepezil or Aricept. And it is very common for both of those medications to be used together. So that is a fair question to ask, I think, if we're not using both medication classes, is that an option? Donepezil does have some GI intolerance with it. Some people just can't tolerate it because it upsets their stomach. But it is, and it has some other side effects, of course, but it's worth asking the question. The thing I would remind you, unfortunately, with these medications is, again, they have a modest benefit at best. So I really tend to think of these medications as sort of icing on the cake when we're talking about the management of dementia. For some patients, they work really well. For some people, they have no effect. So it's not something that either of these medications that we have are going to have a really great effect. You might notice a small benefit. So it's not something that's going to be a huge difference. As far as the reassessment of the medications, even if we're not talking about the memory medications specifically, and I'm a little bit biased here, but I'm always a proponent of having a pharmacist review your medications. There may be other medications that are interfering with those memory medications that are making them not as effective. There may be other medications that can be taken away or that maybe need to be added. So that's always a good thing to have, a medication expert review the medications.
Great, thank you so much, Jennifer. I'm going to direct this next question to both Dr. Fox and Chaplain Greenman too. So Dr. Fox, I'm struggling with how to reassure mom when she is frustrated because she doesn't remember that we tried to prepare her for transitions. It doesn't help to assure her that we called to tell her to expect that we're coming to take her to the doctor. She doesn't want to hear that she can't remember. What can I say? I think both of you could provide some interesting insights to this.
So it's important to remember that she doesn't remember. So reminding her that you did call a lot of times will cause increased stress. And so you can just say, you know what, mom, I'm here right now. We're going to go to the doctor and then we'll get lunch afterwards. So kind of bringing them to the present and not calling their attention to a past event that they don't remember, because that will cause increased frustration. You can also make sure you let if she's in a facility, the nursing staff know, so that when they go in to help get her up in the morning and for breakfast, they can start kind of prompting and cueing, hey, you have a doctor's appointment this morning. Your daughter is coming to visit today. So when she may not remember. Also, sometimes a visual calendar, like, Jane comes to visit at 2 o'clock on Tuesdays and Thursdays, and you can cross off the days on the calendar. That can be kind of a visual clue of she's coming for a visit. She may not remember there's a doctor's appointment, but she at least knows to expect you on that day. So those are a couple of strategies that can be helpful depending on where she is.
Yes, and I'll tell you, I know how I feel, how you feel. I used to drive to take my mom to the doctors, and I'm leaving work. I'm call her the night before, call her the morning before, call her before I leave work that I'm coming. And my goal is to miss as little work as possible, right? So zoom up, get her to the doctors, get her back, and get back to work. Her goal is not that, and she won't remember. I finally figured out she's not going to remember these phone calls. So I did do the phone calls. And I finally figured out that I'm just going to need an extra 20 or 30 minutes when I got to her apartment. This was when she wasn't in a facility. I'll walk in, she's going to be drinking her coffee. She's going to be mad that she's going to the doctor and I didn't tell her. And I'm going to say, "Oh, I'm so sorry, Mama. I was just too busy to ask you. I apologize that I didn't tell you. Why don't we get dressed? We are going to have coffee and ice cream afterwards. Come on, let's go." And I just apologized for not telling her, even though I told her 80 million times, and planned on the extra time. She really couldn't help it. She couldn't remember. She just couldn't remember.
Wonderful. Thank you so much, both of you. So another question here for Dr. Armstrong. What activities happen during the memory clinic?
Specifically for our memory care clinic, there is an evaluation of the person living with dementia, sometimes repeated cognitive assessment, depending on the individual situation, review of medications, review of functional status, both IADLs and ADLs, which is the instrumental activities of daily living, and then activities of daily living. So the person's ability to manage, using a telephone, dialing a number, the things that you do day to day, as well as how functional someone is as far as dressing, bathing, ability to feed themselves. So all of those activities are evaluated. Home safety is evaluated, and this visit is highly dependent on having a very knowledgeable caregiver present with the person living with dementia or cognitive impairment. We also evaluate for any kind of behavioral problems, depression, anxiety, delusions, hallucinations. So it's a comprehensive visit. And then recommendations, medication management may happen, either adding or de-prescribing medications, and then evaluating caregiver stress is another component of what we do in the memory care clinic. And if that's identified, we give people some tools to help them manage their daily stress.
Wonderful. Thank you, Vicki. I'm actually going to put in chat again. It's going to be a file. Hopefully you all can download it. We did a study. It was pretty interesting. My team did a study in Minnesota and interviewed, I think, 12 to 14 different memory care clinics to just get a sense of how they operate and kind of their flow and everything. And it ended up being a really interesting paper in terms of the diversity of how these memory care clinics operate. And it just might be of interest to give you a sense of how different types of memory care clinics kind of approach that question that was posed, which was interesting. And again, I'll post that here in a second. So we have another good question, and I think all of you can maybe address this to some extent. So I'm gonna pose it to all of you. I have ideas on this too. How can we get memory care in the assisted living environment? Mom is not appropriate for secure environment, is independent, spatially oriented, and not at risk for wandering. She needs directed activity and socialization appropriate to her ability. So how would each of you answer that question? It's a good one.
So I think, first of all, it's important to remember that there are great activity programs that are incorporated in assisted livings, where they will have music concerts, they'll have crafts and activities, they'll have reminiscing sessions. So it's really important to meet the activities director for your facility and introduce them to your parent, your loved one, and say, you know, these are her interests. Do you have any activities that are going to be geared towards, you know, arranging flowers, or maybe it's a woodworking, you know, shop, or particular, you know, music that they enjoy. So making sure that they know about that they've just recently moved in that facility, and fostering that connection is a great way to be able to provide some of those, you know, interest in crafts and social, and kind of get to meet the other people, especially if they're new.
What do others think?
So I'll chime in. So as far as like a medication management component for like a memory clinic, if you're looking at the assisted living, if you're looking at assisted living rather, and I can speak really only for Riverside, but for Riverside assisted living facilities, we have consultant pharmacists that go into those facilities and review medications. So from a memory component related to medications, they are making those same assessments. They're looking for adverse effects. If someone is on an antipsychotic, they're looking and making sure that that's appropriate, and does the dose need to be reduced and things like that. So that component is still there in the assisted living community.
Other thoughts from the panel?
From a medical standpoint, most, and again, I can only speak to Riverside assisted living facilities that I'm aware of. Most people in assisted living continue with their primary care provider that they've usually had for years and years. So again, those continued conversations with your PCP are very important, talking about, you know, what's going on, what you know, as a care partner you observe, new behaviors, changes in function, you know, to really make sure that the PCP is aware of, you know, any changes that may require further evaluation, or maybe a change in medications.
And I think Jackie covered very well that the facilities usually have very good activities and things focused on keeping people engaged. The hardest part is getting them to those, because lots of times they'll say they don't want to go. But also, I think keeping them engaged, we can work on as a visitors. We talk in our support group too about when we visit and it's hard to have conversations. You can take activities with you. You can take scrapbooks with you that they haven't seen and look through pictures. I remember at one point, and I shared this with our support group, and a lot of them took it up. At one point, you know, they forget their relationships, so their pictures of the grandkids and stuff stopped having meaning for them. But then I realized, well, gosh, they grew up in New Orleans in the 50s. So I just Googled a bunch of pictures of New Orleans in the 50s. And when I visited, we would look at those pictures, and that, you know, just brought her to life when she saw those pictures, and she smiled and enjoyed them. So I think it gets harder to have conversations. So you need to kind of plan on things to take with you, things to do, and then kind of engage them during your visits as well as what the facility does.
Yeah, these are all great answers. You know, it's interesting. When I saw the question, I thought of it from the standpoint of what should families and others be looking for when choosing or selecting an assisted living facility, and particularly when it comes to memory care. And, you know, unfortunately, I think a lot of assisted living settings, they say they have memory care. They might even have a section of memory care, but I think as families, you have no idea what exactly is going on in that memory care unit or setting or whatever they choose to call it. And I think as families, it's important to ask the questions like, okay, so you call this a memory care unit. How are the staff that in this unit, how are they trained differently than the other staff? What is their training? How many hours do they get? Do they get any dementia specific training? If an administrator or some other person starts hemming and hawing, you know, you're not getting a good answer, that should tell you something, I think, versus a setting that says, no, we're using this program and this is, you know, how they're being trained. Again, that doesn't necessarily tell you the whole story, but at least gives you a sense that at least someone in the assisted living setting understands that caring for someone with cognitive impairment poses different standards of likely requires different skill set than just caring for anybody in the general, client mix in assisted living. I mean, those would be some of the first things I would ask when trying to survey and think about what are the right choices for my loved one in assisted living. The same thing too, in addition to the direct care staff, is ask the activity person. Usually hopefully a good assisted living setting will have an activity director. Ask them specifically, what are some of the activities that you do with people, who might have memory impairment, cognitive impairment, and do some background work yourself to see, are these actually appropriate? Are they effective? Would they be well received by my loved one? I mean, those are the kinds of things you want to dig deep in when you're making these decisions, I think. So.
And Dr. Gaugler, if I could add, some of our Riverside communities, and I know this is present in other assisted livings, have a group of residents who kind of serve on a welcome team.
Okay.
And
Yep.
so they are available to show a new resident, kind of here's the ropes, and here's when folks generally go to dinner, and here's how you find out the calendar that lists the activities or the food that's being served, or when you can take transportation to an offsite program. So that may be a resource to this daughter as well, to have the mother get connected with kind of a welcoming group of residents who've been there for a while.
Wonderful. Thank you, Christy. Well, it's hard to believe. I think we're coming to the end of our time here. We have a few minutes left, and Dr. Jensen had some final slides to share. Before we get to this, I just want to thank the excellent panels today. I want to thank the attendees for the wonderful questions you asked. You can kind of see how this more interactive approach, I think, really helps us address in depth some of the key issues related to living with dementia and caring for someone with dementia. So I want to thank all of our panelists in Riverside Health certainly today, and all of you for attending. But again, Dr. Jensen has several slides she wants to share with you, and then I'll have some final comments before we adjourn. So please, Christy.
Sure. Thank you, Joe. And again, thank you all for being with us this morning. There may have been a few other questions that we didn't get answered. So in just a minute, you're going to see a slide with my contact information and Dr. Gaugler's information. If we can answer the questions for you, we'd be happy to, or we'll pass them out through this panel. I wanted to close today by inviting you to, if you are currently providing care to a loved one with memory loss and you reside in the region of Virginia that Riverside serves, you may be eligible for a really unique study that we're partnering with Dr. Gaugler and his team at University of Minnesota on, and it's to test out a tool for us. And the tool is called Care to Plan. And in this tool, you would take a few minutes to answer some questions online, and then receive some very tailored and recommended resources based on the way you answered the questions respective to your situation. So we have a toll-free number and an email address. I'll show that again in a minute and on another slide. But just wanted to make you aware of this pretty unique opportunity to help us test out this tool and give us feedback. So this next slide shows you that this would be a series of a few months. We'd be asking you to participate. All can be done from the comfort of your home as long as you have internet access and phone access. And part of the participation in trying out the Care to Plan tool is that an opportunity may be available for you to partner with our senior care navigators within the health system. There's also an opportunity to receive a stipend or some compensation for your time, up to $75 to $100 for answering the surveys and testing out the tool. So again, just wanted to make you aware of this. This is funded through federal research dollars through the National Institute on Aging. We're very pleased to bring a tool that Dr. Gaugler has established in Minnesota here to Virginia. So again, here's the contact information by the toll-free number and or an email address if you'd like to reach out and get more information. Then we'd be connecting you with Ashley. She's our colleague here as a part of the panel today with Dr. Gaugler's team. She would have a phone call with you just to verify eligibility and tell you about next steps to get involved. So please consider helping us test out that tool. And before I pass it back to Dr. Gaugler to conclude, There is a link being posted in the chat now, and it will come as an email to you separately where we're asking you just to answer a few brief questions to evaluate today's dementia Q&A panel. Again, my contact information as well as Dr. Gaugler's, and on behalf of Riverside Health System, we really appreciate you spending the morning with us, asking such insightful questions. And again, thank you to the panel and Dr. Gaugler.
Wonderful. Thank you so much, everyone. Thank you to the panel and attendees. Again, please complete the evaluation link after the conclusion of our presentation here today. We also will be, again, sending you the recording, sending you the slides, and also I think we're going to save the chat too to send to you, because I think some good resources have been shared there for you as well. Thank you again, everyone. Hope you have a wonderful rest of your day. And again, if you have any questions, if there's anything we can help with or answer, please don't hesitate to either contact me or Dr. Jensen at the phone numbers here provided. Otherwise, thanks again and really appreciate your time today. Bye, everybody.
Bye.